Bismillah ar-Rahman ar-Rahim. Welcome to SAS 2020. Our session is going to be about regional anesthesia. Before that, I would like to thank organizing and scientific committee and Canal for the excellent job. I'll introduce myself. My name is Tariq Al Zahrani. I'm a professor, consultant, regional, and cardiac anesthesiologist in King Saud University in Riyadh. My colleague is going to be co-chair for the session with Dr. Salah Al Shaghroud. He's a consultant regional anesthesiologist in King's Abdulaziz Medical City in Riyadh. Our speaker today is Dr. Husni Akkad. He is consultant in regional anesthesia and pain medicine with special interest in ultrasound-guided interventions and point-of-care ultrasound. He will present some update about the regional anesthesia safety and outcome and its utilization during the COVID time, and also talk brief about the Adductor Canal block for lower limb surgery. Welcome, Dr. Husni.
Thank you very much for the introduction, Dr. Tariq, Dr. Salah. Let me share my screen. Today's presentation is about regional anesthesia in the COVID era. I would like to thank Dr. Ahmed Abdul Mu'min, Dr. Mohammed Al Harbi for the invitation and for arranging this excellent symposium that is a virtual symposium, and thank Kunuz Ritaj for this excellent preparation as well. I have no disclosures, and of course we are in the Corona era now. It's COVID time, and the talk will be a bit hot. So I'm going to start with regional anesthesia outcomes versus general anesthesia. This is one of those overlooked subjects. We don't discuss it much as regional anesthesiologists. We would love to, hold the needle and do the block, but let's talk about outcomes, because they do reflect on our decision when we want to perform an anesthetic on a patient during COVID time. And after finishing the subject, I will be talking about the Adductor Canal block, 5-minute talk, practical points. Now, most of the outcome talk is taken from regional anesthesia and outcomes. This is a review written by Hatton, Ricky Brull, and Alan McFarlane. Now, Ricky Brull is really interested in outcomes and complications. Their article contains all of the resources that you need if you want to dive more into these. So when you talk about outcomes, we have patient outcomes, surgical outcomes, and institutional outcomes. For patient outcomes, which are usually the most important when we work as patient-centered, team, many outcomes could be, measured or looked at. We start by acute pain. So what I'm going to do now is just mention the evidence facts that are available. I'm not going to discuss the papers that discuss them. So just mention the evidence as an outcome. So epidurals and peripheral nerve blocks have always been shown to provide superior analgesia to general anesthetic. They always reduce opioid consumption. Peripheral nerve block single injection, however, has a caveat. It increases rebound pain, especially when we don't do proper education to the patient, because when the block suddenly wears off and they don't have a baseline of opioid in their system, these patients get severe pain and they come back to the hospital. So they should be getting multimodal analgesia and maybe a small prescription of opioid, and maybe use some adjuncts, like dexamethasone to prolong the block. What about chronic pain? So chronic post-surgical pain is a real problem. It ranges anywhere between 5 to 10% depending on the type of surgery. And it's the risk factors include the type of surgery. So thoracotomies up to 10% could have it. Many other risk factors like pre-existing pain or pre-op opioid use. But one of these factors is severe post-operative acute pain. So I have just mentioned that acute pain management with regional anesthesia is superior to general anesthesia. So what is the evidence that is available for chronic post-surgical pain? Epidural has been shown to reduce it in thoracotomies, and studies have gone up to 6 months, and the result was the same. Paravertebral blocks tend to decrease chronic post-surgical pain after mastectomy. The evidence is not strong, but it is there. However, there is no evidence for other regional anesthetic techniques that reduce chronic post-surgical pain after surgeries. However, there appears to be a role for regional anesthesia. Post-operative nausea and vomiting, which is one of the most important outcomes for patients. So nausea and vomiting would increase PACU stay, would increase day surgery unit stay. So that's extra cost, extra resources needed. Unplanned readmission, so patients go home and then they come back because they're vomiting. A meta-analysis shows that regional anesthesia reduces the risk of postoperative nausea and vomiting, and that's mainly when it's peripheral nerve blocks. Spinal, on the other hand, and we know when every time we give a spinal to a pregnant lady and her blood pressure drops, she says that she feels that she wants to vomit. So we have this hypotension, and we have the vagally mediated GI activity caused by a sympathectomy. It can lead to nausea. Most of these studies had a bias, though. They compared regional anesthesia versus general anesthesia without giving prophylaxis. So we don't know what the numbers are exactly if we give prophylaxis, but generally regional anesthesia has a positive outcome compared to general anesthesia. I mean, regional compared to general. Sleep quality. Now, sleep there's a subspecialty in sleep, so it's a very big topic. I don't understand much about it, but it's interesting. So what we care about usually is sleep apnea, and regional anesthesia does reduce complications related to sleep apnea because of the reduction in opioids. However, when we talk about other sleep issues like duration, REM sleep, they are reduced when there is pain, and they increase nociception. And when there is an increase in nociception, you've got this cycle of decreased sleep. Eventually, there would be a rebound increase in REM sleep, which could lead to MI, stroke, and hemodynamic instability. And studies have not shown that regional anesthesia improves these effects. So except for the sleep apnea, the others are not affected. Post-operative cognitive dysfunction and delirium. Major issue. Now, delirium could be a cause or a risk factor for post-operative cognitive dysfunction, which is a long-term deterioration in cognitive function after surgery. It impacts patients, families, and institutions. Prolonged stay, they need help. More staff needed to clean the patients or help them through. Now, we do know that regional anesthesia reduces pain and reduces the stress response to surgery. However, a meta-analysis did not prove that regional anesthesia reduces postoperative cognitive dysfunction. Another Cochrane review looking at hip fracture patients showed that neuraxial blocks do not reduce postoperative cognitive dysfunction. So the theory here is that this dysfunction is related to the actual stress of the perioperative period and the surgical stimulus per se, no relation to the anesthetic. Cancer recurrence, again, one of the hot topics that are being reviewed. Again, we know regional anesthesia reduces the stress response and reduces the amount of opioids given, which hopefully improves host immune response. Local anesthetic on their own, they actually increase apoptosis and decrease proliferation of cancer cells. So in theory, they should be reducing the cancer recurrence. And there was a retrospective study showing that paravertebral reduces breast cancer recurrence, or a trend towards. But the most recent systematic review did not prove that for any other type of cancers. And if regional anesthesia had a role, it is unlikely to be a sole factor. One of the issues that that could have a role is that volatile anesthetics actually act similar to opioids, and they could reduce the immune response. So when we use regional anesthesia, we avoid using a volatile anesthetic. So which one is the cause of this reduction in cancer recurrence? So overall, it's good, regional anesthesia. Now, morbidities. When we talk about pulmonary complications, this is usually the major thing related to, the advantage of regional anesthesia. Epidurals in every study reduces pulmonary complications. Spinal anesthesia reduce respiratory complications, pulmonary complications. Regional anesthesia is suggested to decrease complications, but there is not much evidence. However, someone with a breathing tube on a mechanical ventilator versus someone who's awake and breathing and talking to you, it makes sense. Cardiovascular complications. Now, two recent analyses for lower limb surgeries looked at that. One of them showed that there is decrease in cardiovascular complications, and another one showed that there is no significance. Other studies showed that when combining neuraxial blocks with a general anesthetic, so an epidural that is running intraoperatively with hypotension happening, there is an increased risk of MI, but not necessarily mortality. So hypotension is something to always be looked at carefully and treated immediately. Cerebrovascular, so they looked at carotid endarterectomy. The problem with the studies that were done is that they are heterogeneous, comparing local anesthetic, different types of regional anesthetic, whether doing a cervical plexus block or anything else. However, they didn't show that there is a significant difference compared to general anesthesia. With regards to neuraxial anesthesia and orthopedic surgery, there is a trend that it might reduce cerebrovascular complications. So that's good. What about DVT? Now, I always remember, during our training and how we train our residents, that regional anesthesia does reduce DVT risk, especially when we talk about joint arthroplasties. But the most recent evidence is showing that with the development of DVT prophylaxis protocols, there is no difference between regional anesthesia and general anesthesia. So not much difference in outcome here. GI effect, so epidural reduces ileus, so that's better. The patients pass gas earlier and maybe discharge earlier. But surgeons always complain that an increase in peristalsis happens because of this, and hypoperfusion because of hypotension, and there is an anastomotic leak. When we look at it, sometimes we see that there are more anastomotic leaks with a certain team rather than the other. However, so evidence has disproved this theory, but there's always this discussion with the surgeons. However, when you look at the surgeons who follow evidence-based medicine, they look at ERAS protocols and they follow it. Actually, those surgeons would come and say, please put an epidural in my patient, because they know that it makes a difference and improves outcome overall for their patients. Urinary retention, of course, spinals. Most of us do long-acting, bupivacaine spinals with opioids. This does increase urinary retention, but peripheral nerve blocks, although there are no studies looking, but the logic says that it does decrease the risk because you're just blocking something that is peripheral, so nothing central. What about blood loss? Every study has shown that there is a decrease in truncal blood loss or lower limb surgery blood loss when neuraxial anesthetic is used. ICU admission. Well, interestingly, there is a reduction of ICU admission with regional anesthesia. It is likely due to a decrease in pulmonary complications. So this is a huge benefit. What about mortality? One would think, regional anesthesia might reduce mortality, but generally it does not. It has been studied thoroughly, except when you look at obstetric anesthesia literature, it did reduce anesthetic maternal mortality related mainly to airway complications in the past 30 years. For lower limb surgery, and if you look at Mark Newman, he studied this subject, over and over again, trying to look at any differences. Let's say in hip surgery, especially, there is not much difference. So I always say, doing a spinal anesthetic, yes, it does have its advantages in a hip surgery. If your surgeon can do it in an hour, great. But if the surgeon is going to take 4 to 6 hours during this hip fracture surgery with major blood transfusion, then is it actually safe to do a regional anesthetic on these patients? What about AAA? There's an interesting study showing an increased 5-year survival if you use an epidural with a general anesthetic. Now, most of the AAAs that we do receive an epidural, regardless of the fact that we heparinize these patients and but we take all the precautions for these patients. Peripheral nerve blocks avoids hemodynamic compromise of neuraxial blocks. So we would think that they should improve mortality in high-risk patients. Evidence is lacking, yet, as experts in regional anesthesia, we would want to do it. And we see that the patients seem to be doing better, but we don't have any follow-up studies. What about patient satisfaction? In general, patients are happier with peripheral nerve blocks and central neuraxial blocks, especially day surgery patients, because of the reduction of nausea and vomiting. But some of them complain, that they don't like having their arms heavy or whatever other complaints, but mostly positive. Now, what about surgical outcomes? Looking at lower limb arthroplasties, so peripheral nerve blocks definitely again improves pain, so better joint mobilization, earlier physiotherapy, increased walking distance up to 6 weeks after surgery. But unfortunately, studies did not show a difference in functional outcome or health-related quality at 1 year mark. There is another problem, that is the motor and proprioception blockade, leading to increased risk of falls. So you always find this subgroup of surgeons saying, please do not block my patients because they had a negative, experience with a patient falling and then, suing them or suing the hospital. Modern regional anesthesia now is moving towards more motor sparing blocks, things like Adductor canal blocks, IPAC blocks for lower limb, for example, facial plane blocks, truncal blocks. Many regional anesthetists are moving towards those now. Vascular surgery. So for AV fistula creation, all the studies have shown that regional anesthesia is superior to local anesthesia and general anesthesia. The reason we think is sympathectomy leading to decreased thrombosis and vasospasm. So even these effects, the success rate, which is immediately after surgery, is actually long lasting. They've studied it for up to 3 months, and it showed that regional anesthetic is superior. However, looking at lower limb, arterial grafting or reconstructions, a spinal anesthetic or whatever different regional anesthetic is used, yes, it does a sympathectomy. Yes, it does decrease the regrafting or thrombectomy while the patient is in-house, but it fails to show a long-term benefit. But still, who wouldn't take a short-term benefit? Surgical site infection I found to be very interesting, that it was studied comparing spinal or regional anesthetic versus general anesthetic. Now, regional anesthesia helps maintain immune response compared to general anesthesia because of the use of volatile, as I mentioned. And the recent meta-analysis showed that it confirmed that there's reduction of surgical site infection when regional anesthesia, mainly neuraxial anesthesia, is used. I found to be interesting. What about institutional outcomes? Now, the whole world is there's a change in the direction of healthcare and the way it is run. So institutional outcomes are now extremely important to be able to run a hospital at a high level and maintain service to the population. So what about length of stay and readmission, which are very important for bed utilization, for the expenditure? So studies have shown that combining all specialties, length of stay is shorter with regional anesthesia. However, it was not as we thought it would be, or it's not days, it's just hours of difference. So the difference is very small. Readmission rate, however, has been higher with general anesthetic, regardless of the fact that we have this issue with rebound pain after regional anesthesia. But general anesthetic patients tend to come because they're sleepier, because they're vomiting. So this is something that could be used if you want to build, a block room or regional anesthesia center. There are many papers that could help you with management to move forwards. What about OR output? Well, regional anesthetic reduce PACU time. So patient arrives, they're awake, 10 minutes, they just finish up the paperwork and send them. And in some centers, they have, bypass of the PACU if the patient's last sedation was more than half an hour ago. So that actually saves time, bed, and resource. But day surgery unit time did not differ much. There are many logistical reasons for this. But for regional anesthesia, that's when including neuraxial anesthesia, the discharge time was prolonged in day surgery unit mainly because of the voiding issue, not able to urinate. So this is why the time difference is not big. In terms of OR output, having a block room could increase efficiency. Now, when we talk about COVID, could we use a block room? The answer would be no. It has to be in the OR to avoid cross-contamination. What about cost? Institutions care about cost. So when we talk about reduced pain, better patient satisfaction, so reduced pulmonary complications, reduced blood transfusion, reduced ICU admissions, reduced readmissions, facilitating day surgery. So some patients can go home. At some centers we are not at that level yet, but if they can go home with a catheter and an automatic pump, they don't have to be admitted. A decreased turnover time in the OR, meaning you have more cases to be done. We don't use as much anesthetic drugs. We don't use anesthetic gases. The machines not being used. All of this would reduce the cost dramatically. Now, even if these outcomes that I just mentioned were just a trend towards rather than a significant change, when putting all together, regional anesthesia does have a positive impact on cost. And this could be a summary of what I've just discussed. These are very important things to put in mind. Now, coming to COVID and talking about the regional anesthesia outcomes versus general anesthetic and how we can implement this during our regional anesthesia practice when we have COVID patients. So there has been a joint statement by the American Society of Regional Anesthesia and the European Society. They had a summary. So the first slide of their summary, they state that regional anesthesia is preferred over general anesthesia for patients with COVID to reduce the risk of transmission. So I'm going to present what is the joint statement and their recommendations, and then we're going to have some discussion about it. This is difficult to read, but I'm just going to summarize it. Basically, use safe practices, so don appropriate PPE, what we've mentioned before, in all the presentations before us. Take your time in doffing. Regional anesthesia are not considered aerosol generating, so this is the key thing with regional anesthesia. So they do not recommend using an N95. So basically, a face shield, a surgical mask, goggles, and a gown, which prevents any liquid from reaching your body. But if there's a high risk to convert to general anesthetic, then an N95 is warranted. Patients should all wear a surgical mask, and if they're using a face mask for oxygen with the lowest flow possible and the mask on top. Some studies have shown that the mask is placed, the oxygen mask is placed on top of the face mask, but anyways. And ensure that the ultrasound machine is covered by plastic drapes. Choose the right procedure for the right patient. There is no contraindication and no change in the medication doses. Regional anesthesia is preferred according to the joint statement. Prepare and pack all the required drugs. You don't want to be going in and out. Even if you have a runner, still, you don't want any cross-contamination during the procedure. Use blocks that preserve respiration. So maybe avoid interscalene or supraclav if you're worried about a pneumothorax or a phrenic nerve palsy, especially if the patient already has respiratory compromise. So use a distal block, something like an axillary block, an infraclav. What about using adjuvants? So dexamethasone could reduce immunity. For example, a clonidine or dexmedetomidine could cause over-sedation. So we might want to avoid these when we do our blocks for these patients. We use ultrasound all the time to avoid getting into local anesthetic toxicity, to avoid intravascular injection. There is no dose adjustment recommended for these patients, but we have to calculate the dose because we don't want to turn into an emergency situation because of a toxicity. Be vigilant. So we should test the regional anesthetic before cutting, because we don't want to convert to a general anesthetic. Again, use minimal supplemental oxygen. One thing is that COVID patients have been shown to be to have more thrombotic issues, but they also could have thrombocytopenia. So we always have to look at their platelet function, platelet number as well, before neuraxial procedures. If you're doing a spinal, watch and prepare for hypotension. So you should have your phenylephrine or ephedrine syringes ready. There is no time to go in and out. But studies have shown that they don't have an increase, tendency towards hypotension, but just be ready. What about epidural blood patch? So the recommendation is to delay, if possible, as long as possible, to avoid injecting viremic blood. However, if the patient is having, it's weighing risks and benefits. If the patient is having, neurological signs or danger, then we have to do it. These are the things I've just mentioned. Now, of course, using the standard monitors, reducing sedation as much as possible, and talking the patient through these procedures. We don't want them to have respiratory depression. So what's the point of doing a block if we're depressing their breathing? For central nerve block, now, lots of new studies are coming out showing that CSF might contain the COVID virus. Although in the past, recently actually in August 2020, Lucchesi from Italy reviewed samples from France, from Germany, and from 2 other studies, so up to more than 100 patients who actually had COVID neurological complications. So they came in with neurological issues. All of them had negative CSF except for 2, which were slightly positive in France, and they were thought to be related to contaminated CSF. So the main thinking is that the neurological complications related to COVID are autoimmune response rather than viremic, but some newer studies now are showing that it could be direct virus effect. So when doing a spinal, just make sure that avoid contamination. Don't let the fluid drip much, and make sure that you're wearing appropriate PPE and shoe covers as well. Now, for epidural blood patch, when we talk about post-dural puncture headache, there is the sphenopalatine local anesthetic infiltration. This is not recommended because it could be aerosol producing. Now, having said all of this, these are the recommendations of the Joint Task Force. This is another study by Alan McFarlane. Alan seems to be producing lots of papers that are quoted during COVID, and very interesting papers, very well written actually, from the UK, from Glasgow. Regional anesthesia and COVID-19, is it the first choice at last? So the writers of this paper eventually reached the point where regional anesthesia is advantageous. However, they play the devil's advocate, and they look at different aspects or different things to think about. So I'm just going to take a few things from their paper. They've mentioned that out of the 106 UK doctors that died with COVID, none of which was an anesthetist or an intensivist, which tells us that even though that we are the people doing the most airway airway procedures, aerosol generating, we are doing it well. So with full muscle relaxation and avoidance of aerosol generation. And we are donning appropriate PPE, so our guard is high. We are always, vigilant. Another study in China, or a case series, showed that there are more infections in doctors performing spinals and not wearing their whole, encapsulating suit, which, was telling them, is this related to, not wearing appropriate PPE, or is it because it was a spinal? Their guards were down, so they had more breaches during the procedure. Still, regional anesthesia is being said to be safer than general anesthetic because there's no airway, no aerosolization. But always remember that even with an awake patient, when they cough, when they sneeze, even when they talk loudly, this could generate aerosols. So where do we stand? What about the PPE differences? So now most institutions, I know here in Canada, I know in the UK, according to their study, in the United States, in many countries, they have issues with N95 supply. So the recommendation is always, if there is no aerosolization, to use just a surgical face mask with the goggles or a face shield and the gown. So does this make a difference? Because now we have a regional anesthetic with a patient that is awake. So we are a bit, lower guarded with no N95, and then the patient maybe, I don't know, vomits. A patient starts coughing because they have a, phrenic nerve is affected, or whatever it is, and then you're trying to help the patient. Do we breach our PPE in this situation? Is it a safe practice? So these are just questions to think about. So this is the self-awareness or situational awareness while we are doing a regional anesthetic versus general anesthetic. What are some of the advantages of a regional anesthetic during this pandemic? Well, in many countries, they ran short of drugs, especially propofol in the ICU. So there's, improved drug resources to ICU. We don't have to use as much in the OR. Potentially facilitation of patient discharge. So if they don't need to be in the hospital, you just block them, and once they regain their sensory motor function, day surgery unit, not day surgery unit, I mean, but just discharge them home as soon as possible. And then we have the subset of hospitals with poor ventilation. They either don't have negative pressure rooms, they don't have, the 12 or 14 or 15 or 20 circulation per minute. We always have to try our best to avoid aerosol generating procedures. And so in these situations, I think regional anesthetic could be advantageous. Always think, what if we need to convert to general anesthetic? And as I mentioned, letting our guard down without the N95. So the recommendation is, if regional anesthesia is considered, always ensure safety procedures are followed. PPE donning and doffing, especially. Most of the breaches are done during doffing. Ensure an expert regional anesthetist is doing the blocks. This is not a time for learning and not a time for failure. The block has to work. Otherwise, just stick to the general anesthetic with the appropriate, taking care of every step of the way. This is a very important subject. Understand the type of surgery, understand or know your surgeon, and the competency of the team you are working with, and the risk of conversion to general anesthetic. We were discussing this, me and our respected panelists, before your attendance. And, a center that does a total knee replacement in an hour, there is another center that does it in 4 or 6 hours. So you should know your surgeon and your team before deciding to do a regional anesthetic, because then you're just doing 2 procedures instead of 1 if you do a spinal and then put a GA on top of it. And this GA now is more of an urgent GA, so we might lose some of our PPE steps. If you talk to a patient and there is no apparent benefit between a general anesthetic and the regional, perhaps a general anesthetic that is well executed could be better. Of course, consenting the patient, if the patient says no, they have the right. We cannot force them. But during this COVID time, we can actually tell the patient our thought process. We can tell them, we think it is safer for the staff, it is safer for the nurses, and it is as safe as a general anesthetic for you in terms of risks or complications or outcomes. This is why understanding the outcomes is important. It is not coercing the patient. We are in a pandemic, we need to be safe, because losing one physician, one anesthetist, to quarantine for 2 weeks, let's say the average patients that we see are 5 per day, we lose, we stop giving care to 50 patients. So we don't want to get sick. We want to be as safe as possible. And now let's cool down from the topic of the regional anesthesia outcomes and the COVID era. I'm not sure if I convinced you to do regional anesthesia or no, because I still, I still would have to take it on a case by case And or if I have like a question mark, I will just secure the airway and make sure that everyone is safe, and rather than doing something that I'm not sure about. What about doing a general anesthetic where you do a block under general anesthesia, like a tap block? So the recommendation by the Joint Task Force is that please do not do extra steps. If you do a general anesthetic, just keep it as a general anesthetic and give systemic opioids. If you are not an expert in regional anesthesia and you feel most comfortable doing general anesthetic, then stick to general anesthetics, because this is going to be the safest for you and the patient and the staff around you. So these are, I think, the takeaway points from this lecture. Now, shifting gears, I've been asked to talk about adductor canal block, and it's a 5-minute talk. It's a practical talk. It's basically adductor canal block is a saphenous nerve block done for mainly knee surgeries, so either total knee replacements or knee ACL reconstructions. We will talk about advantages and disadvantages. Indications, as I mentioned, knee surgery. We can supplement for foot and ankle surgery. So if you have a complex ankle surgery and you do a sciatic block, but there is a saphenous component, so rather than doing a full femoral block, you could basically do an adductor canal block and cover the saphenous nerve, because the saphenous is a sensory nerve, and you prevent motor blockade above that. And some papers talk about saphenous vein stripping or harvesting. Honestly, I have never done the block for such a procedure. Now, understanding the anatomy is important, and we always talk about the sartorius muscle. It's the longest muscle in the human body. If it comes in an MCQ, what is the longest muscle? It's a sartorius. And it's very important to know and understand and develop a relation with, because it is our guideline mainly. And then we have the adductors. So we've got the adductor longus. When we talk about a proximal block, it turns into an adductor magnus here when we become more distal. And then we've got the vastus medialis muscle. So these are the the roofs and sides of the adductor canal. So when you take a look here, you've got the sartorius muscle. It's most triangular in shape when you see it on ultrasound. And the vastus medialis, this is a lateral side. And you've got the adductors on the medial side. The vein runs beside the artery, sometimes above, sometimes below. And there is a very important, the saphenous nerve is usually lateral, but sometimes as it dives deeper, when you go more distal, it goes to the lateral side. So I will mention why this is important. Now, when you're looking at the shape, so there has been a major debate between the Canadian group and the Danish group and the American group. What should we call it? Should we call it saphenous nerve block? The Danish group says, no, it's a femoral triangle block. It's not an adductor canal because it is not a continuous canal. Then the Toronto group says, but we've done it on cadavers and it shows that there is a continuation of this canal. And some people call it the subsartorial block. This is why we need to know the sartorius muscle. It's a subsartorial block. So the scanning technique, basically, of course, the standard monitors, aseptic technique. The patient would be lying supine and the leg is slightly externally rotated. And you can see, I don't know if my mouse pad is shown or the mouse pointer, but this is the knee. And this is the, where you find the femoral nerve. So the crease, sorry. He's doing it midway, somewhere midway. So look at this linear probe. This is an 8 centimeter needle, echogenic needle if possible. A lateral to medial approach with the ultrasound facing you on the other side. Most of the new studies are talking about injection of 5 to 10 mLs of solution only. So I was used to injecting 20 mLs, but now I reduced to 10 mLs. Why? I will mention why. So looking at this slide, so this is the femoral nerve. As you go, you get the saphenous nerve, and then there's the nerve to vastus medialis. So if we do the block in the proximal third, we block the nerve to vastus medialis every time, which can cause ultra blockade, leading to decreased leg extension at the knee and potentially instability of the patella. Now, so some people say it is important to maintain this strength, and some people say, you know what, it's a very minimal issue. It doesn't matter if it's blocked or not. But then if we do the block proximally and we inject a lot of local anesthetic, it will track back to the femoral nerve, which will eventually lead to quadriceps weakness. And this is why we're doing an adductor canal, is to avoid the quadriceps weakness, because it can lead to falls and some difficulties with physiotherapy. Now, some people advocate for the distal 1/3 to do the block here. Sometimes it is a bit more challenging, but most of the time, the view that you will see on ultrasound looks the same, very similar. However, the saphenous nerve could travel deeper or could go to the other medial side. This is why when we do the injection, which I will show you. So now we do the ultrasound scan. Usually when you put the ultrasound, the first thing you will encounter is the femur, which is not shown on the ultrasound image here, but it will be a hyperechoic shadow and a hypoechoic or a black shadow behind it. So you just move your probe medially in the thigh until you find the femoral artery. In some locations could be the deep genicular artery. It's very obvious. It's large and it's pulsating every time. The depth ranges. For most patients, you'll find it within, maybe 4 centimeters, but in some patients, it could be even deeper. But the moment you see it, the view is almost always the same. You see this triangular kind of shape with a thick fascial plane in between the sartorius muscle and the vastus medialis. Remember, this is the lateral side where we will be coming in from. So insertion of the needle in plane approach. The needle goes all the way in and you try to pop into this fascial plane, and using liquid, so whether saline or if you have your local anesthetic syringe on, it's fine, start injecting. The moment you see the fascial plane splitting and the femoral artery being pushed away from the sartorius muscle, you know that you're in the right position. So most papers talk about injecting just on the lateral side. The way I was trained, honestly, is once you get half of the solution on this side, then just try to track a little bit beside the artery or above the artery to track the fluid to the other side too, because sometimes the nerve or some branches could be traversing there as you go more distal.
Sorry to interrupt you, but please, we have 1 minute more because we have time to discuss the questions with
Sure. I took my time according to your recommendations. Okay. Yeah, all right. I will be done. Okay, so advantages, less motor blockade, basically. Risks are very low. So even the local anesthetic systemic toxicity is very low. Arterial puncture, 1 reported case of pseudoaneurysm. The evidence, you see 26 systematic reviews have been done. The results mainly showing equal effectiveness of adductor canal block and femoral nerve block, but reduced risk of complications, so better muscle power and faster ambulation. But there is an interesting thing, is that local anesthetic infiltration by the surgeon, pericapsular, tends to provide better analgesia. Thank you.
Thank you so much, Dr. Husni. It's a nice talk. Now we have almost maybe 10 minutes just to run and go to the questions from the attendee. If you don't mind, Dr. Salah, to help me for this one, please.
Thank you, Dr. Husni, for this interesting presentation. We have a couple of questions here, but for the sake of the time, we will go through some of them. There is a question: how could the block room decrease time consumption?
Okay, so at the center where I trained, we had a block room which had 5 beds. It's like musical chairs. So it serves 5 ORs. Basically, the patients are brought in at 7 o'clock. OR time starts at 8. We do those 5 blocks, including the spinal anesthetic that is associated with it. The patients are taken to the OR, given antibiotics and checklist is done and surgical incision is immediately done. So you avoid the induction time or the injection time, which is spent in the OR. Usually takes time to scan. All of this is done in the block room. And then midway during those 5 surgeries, they're still running, we call for the next patients and we block them. Usually, you know, while they're doing the cement, they ask us to do the spinal. We do the spinal. By the time it kicks in and it's heavy and good, the patient is taken to the OR. So, and of course, because it's a regional anesthetic, there is no extubation time and no turnover time. The turnover is basically just cleaning, which takes 10 to 12 minutes. So this is how the utilization gets better.
Yes, I think with the overlapping also, this will reduce the time and the time waiting also for the local anesthetic to kick in and to start to.
Correct, correct.
Another question here, do you prefer to use pressure monitoring during injection to avoid ischemia to the nerve? And what simple method to do?
I would love to, honestly. You know, the evidence is very compelling. And I have seen the samples. Unfortunately, I didn't get my hands on, you know, a bunch of them to be used in my daily practice. But if you have them, use them. Use them. Absolutely.
Okay. Dr. Salah, if we can choose some questions related, and there is questions from Dr. Ismail Ahmed. COVID-19 patient usually anticoagulated, not candidate for regional anesthesia. I don't know how to answer this, Dr. Husni.
So, so there is some recommendations to anticoagulate the patients. If the patients are, you know, on anticoagulation and they need to maintain it, then this is a contraindication. But if this is many of the patients, you know, who are mild, you know, most of the patients are actually being sent home. Let's say someone is being sent home, they have good respiratory reserve, maybe a little bit of shortness of breath, a little bit of fever, but they are fit to go home and they fall and they break their legs. They are not on anticoagulation. So these patients are fit for a regional anesthetic.
Okay. Another question here about the post-dural puncture headache and in COVID patient and blood patching. Blood patching while the patient is having viremia,
so it could pose a problem. There has been case reports of COVID meningitis, and this is the main problem. This is the main, you know, scare. What if we breach the, you know, the area and the viremic blood goes into the CSF and causes this meningitis? So, so according to the recommendations, because I haven't dealt with such a patient before, they say you should avoid until the 2 weeks have passed or the viremia is treated. But if the patients are showing, you know, debilitating symptoms, you know, that could actually lead to a subarachnoid hemorrhage, let's say, then there is weighing risks and benefits. But I haven't read any case reports of it being done yet. So, so I assume everyone has the same question.
Yeah. Okay.
If SpO2 is above 94, do we need oxygen supplement to COVID-19 patients?
I honestly don't know. Usually I give oxygen supplementation to patients that will be receiving sedation or deeper sedation. Sometimes we say, you know, we're causing tissue injury while we're doing surgery, so we need to improve the oxygen supply to this injured tissue. But there's some other evidence showing that, you know, in C-sections, for example, sometimes or most of the time you don't need to give supplemental oxygen. So I think if the patient is tolerating, they might not need oxygen, especially if it's a peripheral surgery. If they need some sedation, a little bit of fentanyl or midazolam, and they're getting sleepier, SATs are starting to fall, then maybe they need some supplemental oxygen. But again, anything to be maintained, you know, above 92, 93%, with the lowest amount of oxygen needed. That's what I would do.
Okay. can we use cross-match blood for the batching? I don't know. This is the questions. But
I don't know. I thought about it. Yeah, I thought about it. I don't know. I don't think the coagulation factors are good in that blood to cause a similar effect. So I don't know.
Okay. Tips for the successful block.
That's a different subject. Yeah, make sure you understand the block very well. Make sure that you've trained with someone who has done it, being supervised by someone who has done it, or have done it on mannequins, read more about it. Ensure that you're using the correct local anesthetic dosage. Ensure that if you're not an expert in this, use stimulation as well as with the ultrasound, just to ensure that you're actually close to the nerve. And if in doubt, just don't inject. Do no harm. Do no harm.
Can add also, you can have plan B. Always keep plan B, and general anesthesia is your safe at any time.
Okay. Okay, thank you so much, Dr. Husni. A very nice and excellent talk. And thank you, Dr. Salah, for having this session. Thank you for that, our attendee for this attending the sessions. And this is the last announcement. Is the last session is going to be the next session about 4:30 with Prof. Steve Shaver. Please enjoy the last session. And thank you so much for your attending and for your practice, Dr. Husni and Dr. Salah. Thank you.
Thank you very much, everyone.